Episode 486, The Secrets to Operationalizing Direct Contracting from an OG. Today I speak with Dr. Stan Schwartz.
American healthcare entrepreneurs and executives you want to know. Talking. Relentlessly seeking value.
Let us begin with something Dr. Rami Khalil wrote on LinkedIn the other day. He wrote, "Is it just me, or is the world of healthcare claims designed to make people feel dumb, asking for, well, myself?" You and me both, my friend. You and me both. And then Ann Lewandowski, she wrote, "David Bolduc and I sat down this morning. The clear message we need to be delivering to self-funded plans is that you are not purchasing health insurance. Full stop, end of story. You are not offloading risk to their risk pool. You simply purchase their administrative services to manage your healthcare finance dollars." And right, we're telling employees to go get screened, to go get a wellness exam, go get a knee replacement, go see your cardiologist. In general, some pretty predictable things. And then every week, we're going to reactively let a third party tally up the volume. And after it's all over, tell us how much it costs vis-a-vis the so-called mystery of the weekly claims wire. Listen to the show with Justin Leader. This feels very, submissive, kind of chaotic. It also feels very expensive. And it is, of course, very expensive. I've heard multiple times from multiple guests, Cynthia Fisher, amongst others, that medical spread. Some TPAs, not all for sure, but some TPAs are scraping off the top. 30% plan total spend times 0.3. That's a lot of money. And add to that, and Leon Wysanowski has posted plenty on this topic, how common it is for prices for any given healthcare service to vary wildly in the same geographic region. Link in the show notes to one service where you go one place in a local geography and it will cost 10 times more than some other place. 10 times more expensive. And what do these two factors, the spread pricing and also some entities in any given market charging lots and lots of money, what do they all add up to if you're a plan sponsor? Well, big renewals, lots of effort needing to be placed into trying to figure out how to balance the budget. So now what if you're a plan sponsor? Well, a very common gambit here is to cost shift to employees. For example, raise deductibles. But one, there are many, but just one point to ponder as a downstream consequence of this raise the deductibles strategy. The higher the deductible, the more clinical organizations become subprime lenders. Mark Cuban wrote this to me the other day, and massive spoiler alert, he's coming back on the pod to discuss this topic with Cora Opsahl, and I could not be more excited. But yeah, if I was in a mood, I could easily argue that when deductibles start to sky, clinical organizations take on more risk for self-insured employers than carriers who literally take on no risk in actuality when the employer is, as I said, self-insured. I've heard way more than once about indie practices, and this really matters because obviously indie practices tend to charge a whole lot less than consolidated health system. So if you're a plan sponsor, you sort of want to make sure that you've got options in your market. And I have heard way more than once about indie practices who simply cannot stay in business because they don't have the infrastructure or the capital reserves to basically be a bank. And not just any bank, but one really bad at vetting who they give loans to because, they actually aren't able to vet who they give loans to. That would be in violation of their TPA contracts and or network agreements. If you're in network and a patient has an insurance card, you got to follow the financial terms as per the card.
Hi, this is Tom Nash, editor and producer of the Relentless Health Value podcast. I bet you're wondering, how can I help Relentless Health Value? Well, that's pretty easy. Have you signed up for the newsletter? The newsletter is great. It tells you when each episode's coming out. It gives you an introduction to the episode with all the mentioned links and a way to click through and listen to the podcast. But there's more ways to help. You can always go over to LinkedIn. Are you following the page? You should be. There's great conversations each week on all the episodes. So go to LinkedIn, find the Relentless Health Value page, and follow us. Have you ever left a review for us on Apple Podcasts or Spotify? That would help greatly. While you're doing that, be sure you're following the podcast so you get notified each week inside of Apple Podcasts or Spotify. Okay, so you've done all those things already? That's great. Another thing you could do, you could head over to our website and donate to the tip jar. Maybe become a sustaining member. In many ways, Relentless Health runs like an unofficial nonprofit, a very, very nonprofit. So anything that you give would help us pay the bills. Thanks so much for listening.
Dr. Kristen Dickerson said something in the interview from last week, in the episode from last week, that stuck with me. We had to cut it for time, but maybe I'll put it in a bonus show sometime in the future. She said, sometimes some kind of slick clinical organizations, when it comes to ordering imaging, they will try to schedule a high deductible patient's image for as late in the year as possible in the hopes that by that time, the patient will have met their deductible and some other schmo healthcare organization will be the one on the hook to have to collect the patient portion. Nothing like not at all timely follow-up depending on when this happens. I hope I just didn't give somebody some ideas. Nah, that type wouldn't be listening to this show. So all this being said, listen to the show with Preston Alexander, listen to the show with Vivian Ho, listen to the 2 Flywheel shows with Jonathan Barron, and all of the deep, heavy topics I just glossed over here are deeply raked over the coals in those earlier episodes I just mentioned. But in all cases, you know, one solution to all of the above? Yeah, direct contracting. Now, this Relentless Health Value direct contracting as a solution trifecta, of course, began with Elizabeth Mitchell talking about it in the Take 2 from 2 weeks ago. Last week, I discussed the upsides and also 3 barriers to doing direct contracting for imaging with the incredibly wise and articulate Dr. Kristen Dickerson from Green Imaging. Dr. Dickerson gave a bunch of proven suggestions to overcome said 3 barriers, by the way. She did not leave you hanging. And now, this week, we're talking mostly about how to think about and operationalize a direct contract with an OG of direct contracting, Dr. Stan Schwartz. What an honor to get Dr. Schwartz on the pod, and I am doubly thankful because he stepped up and offered to help support Relentless Health Value financially, as well as spending his time with me and you. So thanks to everyone over at ZERO.health for being part of the kind of folks who support shows like this one. Dr. Stan Schwartz is co-founder over at ZERO.health. Zero gets members access to high-quality providers for $0 out of pocket, leveraging bundled payments and direct contracting. This episode, as I just said, is sponsored by ZERO.health with an assist from Aventria Health Group. And my name is Stacey Richter. Dr. Stan Schwartz, welcome to Relentless Health Value.
I am so happy to be here. It's one of the things I've really looked forward to.
As have I. So talk to me about the origin story of ZERO.health. I know you started it after supposedly retiring in 2014, and your partner is Jim Milloway, who was working at that time at a brokerage.
We got a group of employers together here in Tulsa, and we got a group of providers together and started offering bundled payments. And it was really an interesting proposition. Quick example, if an employer had a member that needed their gallbladder removal, we had examined enough claims to know that they'd probably pay about $8,000 to $10,000 for that gallbladder surgery. So we had a hospital here in Tulsa. It's a 5-star hospital, Medicare 5-star hospital, a very good place. They were doing bundle payments for an outpatient gallbladder surgery for $5,641 complete. And that was everything. That was anesthesia, the surgeon, the hospital, the recovery room. And the employers liked that. But the only hitch was employers had to cover 100% of the costs so that the employee would pay zero. There was never a hesitation to, I'll just try to hang out this gallbladder problem and hope I don't wind up in the emergency room needing it done on Saturday night at 12 o'clock. And the employers saved money. The providers liked it because they were getting a fixed price. They knew just what they were going to get. They didn't have to collect from the patient. They didn't have to hotbox patients. So they got patients that were all ready for surgery. The employers were saving money, even though they covered the employee's copay and deductible.
You created this bundled payment program specifically to address a known problem, and you knew how to solve for it. This is kind of a very different way to go about things than a lot of, in air quotes, startups or point solutions. Oftentimes, some of the times, it's somebody with a lot less real world experience. They're almost even hypothesizing what the problem is. And sure, you can get in there and then pivot 600 times, but it seems like you knew that if you did this well and you knew how to operationalize it, which do not underestimate that, But if you could do it well, you knew that, as you had said, that patients were getting hot boxed. And this was a while ago, but that's even more true now. I just came back from a conference. There was 3 sessions on trying to figure out how to get the copay out of patients. And it's a thing, especially with the rise of high deductible health plans and the increase in hospital charges. Let's all recognize that if you're paying a percentage of anything, that those numbers are getting real big. So patients are going to be happy about this. Employers, not only is it less expensive, but it's also predictable. You know what the price is. We just had Kimberly Carlson on the pod just talking about all the different ways that things cannot cost what you think they're going to cost, even if you get an, in air quotes, estimate up front, right? So just so much that could be said for doing something the market demands, because someone is intimately familiar enough with that market to know what the market demands.
I think the one thing that some people who want to change healthcare lack is the emotional energy from really understanding how the problem affects individual people. And my epiphany, Stacey, was reviewing claims for a local roofing company here in Tulsa. They were self-insured, had a couple of hundred employees, and we were consulting with them. How could we save money? So I'm going through this, and one thing caught my eye. It was a 23-year-old covered member. He was the subscriber, so I'm sure he was the employee. And at the age of 23 in a roofing company, you're much more likely to be a laborer than a CEO. And there was an item on a bill, $125 for a comprehensive metabolic profile, which everybody knows is a blood chem, one of the most commonly ordered tests. And his copay on this test was $125. I think the total amount was $175, but he hadn't met his deductible yet. He paid $125, a roofing laborer, for a test that's available for $6.52 if you buy it directly. And to me, this just isn't right, because this kid wasn't given the opportunity to shop around for that test. Somebody directed him. Just have you go down the hall, get a blood chem test, and we'll be fine. And we really set about not just to improve the cost of high-cost items, major surgeries, but we realized, you can probably arrange direct contracting for anything that you can schedule. And that became kind of our mantra. If you can schedule it, you can put a price on it. We realized from that, and we started looking at all kinds of low-cost claims, urinalysis, chest x-rays, blood counts, and so forth. And as we looked at where employers could save money, this is the drip, drip, drip of healthcare waste. So much of what we call expense in medicine is simply pricing failure. Something that should be $7, you're paying $100 for. And that's why we started looking at how can we provide everything, even if it's a cheap urinalysis or if it's a major cardiovascular surgery at a bundled price.
I'm sure this 23-year-old roofing worker had other things that he or she would have liked to have spent the $119 on than overpaying for an exam. It sounds like what you thought at that moment in time was, these metabolic exams are really common, as you just said. If you get a wellness exam, every member of your plan is going to get one once a year. So why are we kind of leaving it up to chance? Like if we were thinking about a purchaser at a company purchasing anything else, and you knew you were going to purchase 1 times the total population of your plan on an annual basis, you wouldn't be just like, just go get it wherever.
That's exactly the point. I mean, you're going to buy these things. The only unknown in healthcare is not whether someone's going to need a blood chemistry, it's who's going to need it. As we started looking at claims, we developed an algorithm that would take raw claims, line item claims, put them in the hopper, out the other end. It bundled up those claims to match exactly what Zero could provide. So we could show a company the savings that they would have on any particular test. And I remember this, we were pitching to this one company and we showed them their hair was on fire because of high-cost claimants, which for that company was anybody over $50,000. Just a blood chemistry was a high-cost claimant for them. We could have saved them over $50,000 by just getting the same test done in a different place. And don't tell me that that blood chemistry test is better because you paid $125 for it. It isn't better. We had it done at $6.52 by a very highly respected national firm.
As you just said, what's up for grabs is anything that can be scheduled. If you can schedule it, you can figure out how to buy it better. And I'm thinking about a number of things. And then, spoiler alert, I'm going to wind up with a disruption word, which I know someone is going to be thinking of right now. A couple of thoughts are coming to mind. One of them is this whole idea, and we had G. Bai on a bit ago, and she was talking about generic drugs. But I think same rules apply here, where she's saying, think about it. This generic drug costs $2. If we pay for that generic drug using insurance, then what is the insurer, in air quotes, is going to do is take that $2, spread it over the entire risk pool. This is what's going on behind the scenes. They're taking that $2, they're spreading the $2 across the entire risk pool, and then recalculating what that individual should pay as a percentage of the risk pool for that $2 claim. And you just start thinking about that. And I am disregarding a lot of things like the patient's ability to pay. Not talking about that right now, just talking about the operational logistics of that endeavor, adding so much bureaucracy to a $2 claim. And I think we've just done 3 or more shows mentioning the hazards of employers buying discounts instead of just buying the healthcare services, which is kind of a different flavor of this exact same idea. Why are we adding so much legwork and bureaucracy and making this just so complicated? I think the point that you're making is maybe a plan sponsor shouldn't be paying a third-party administrator, a TPA, to spread every expense over a risk pool, which can cost around 30% of spend, a just wildly, unexpectedly high number, but one I have heard multiple times now as an estimate, most recently from Dan Ross and Mark Flores, but also from Elizabeth Mitchell from PBGH based on their data. And this was a point that she mentioned in the Encore that was aired a couple of weeks ago. So in cases where, as you said, the question isn't if a healthcare service is going to need to be purchased in any given plan year, the question is merely who will need it, then maybe you should just go buy stuff is what I'm hearing. And that's what, in other words, a direct contract is, where you are figuring out how to purchase things using purchasing discipline.
I mean, insurance basically is you pay somebody money to transfer risk to them. So what we're doing now is we are using an insurance mechanism to have somebody else process claims and take care of things that we know are going to happen. You've heard of my light bulb analogy. We've used this so many times. We go into a factory to talk to an employer and we point to the ceiling. You know, you've got what I see about 7,000 light bulbs in this plant. I mean, do you insure every one of those light bulbs and file a claim and wait till you're reimbursed to get them fixed? No, you just go out and buy light bulbs at a good price and you figure out how to get them installed at a good price because you know they're going to burn out. The only thing you don't know is which one's going to burn out. End of story.
Which is a great analogy. Let me ask you the disruption question. Because if you are trying to make sure that every member of your plan who needs a comprehensive metabolic panel in any given plan year, that test gets sent to the preferred vendor, I'm thinking to myself, clinicians have to be on board for this ride. The patient probably needs to know what's going on. If we're just thinking about the amount of logistical effort such that all of these tests got sent to the right place, my mind's kind of exploding right now. How do you handle that?
We make the system so easy and so understandable that it becomes the path of least resistance. So when someone works for a company that has Zero program in place, it's always a voluntary program. We will never let it become mandatory because as soon as someone has to do something, their attitude toward it is totally different. The plan becomes a bolt-on to their underlying health insurance plan. They still have to have their usual Blue Cross or Aetna or UHC, whatever. But we make it the easiest way to go. And we have personal health assistants, for example. We help educate the members that if you call the personal health assistant whenever you're told by a doctor you need to get something done outside the office, they will help you find a place that you can get it done at no cost.
You mean the second that a clinician says, hey, I think you need labs. I think you need imaging. The patient needs to be like, oh, I need to make a call.
We don't try to educate people on the complexity of it. What they understand is if I call this number or I text or I chat with this number, I may pay nothing for it. That is totally understandable. And if they do that, they wind up with an actual stateside human that arranges for where they need to go. They go to like for the lab, they'll go to the lab. They don't have to make a copay, a deductible, or anything. Everything has been arranged for them. If they go into another specialist's office, everything is arranged for them.
I'm tracking back to the episode with Peter Hayes right now, where he was talking about 3 vectors of change in healthcare. And one of them was transparency. Another one was legislation. But then the third one was public outrage, this public awareness of, and maybe this is also folded in with transparency, just public awareness of how easy it is to bankrupt yourself if you go get care. And I've heard varying numbers, but a majority of Americans think real hard about seeking care. And you alluded to this at the top of the conversation, who think real hard about seeking care because they're like, at any moment now, I could wind up with a bankrupting size bill. They're aware of the fact if they go for imaging or if they go for blood work or they go to a specialist who turns out is in a hospital, didn't look like they were in a hospital, but turns out they're in a hospital. So now they get this facility fee or just the rates go way up and they're paying like just any of these various things. I think the public is becoming much more aware of the fact that these are fraught endeavors here. There could be certainly peace of mind knowing that if you called this number, you are not putting yourself and your family at financial risk.
One thing that motivates people to get things done and to be sensible shoppers is to be able to think clearly and not have the primitive brain take over. I will tell you from personal experience with patients, and any doctor will tell you this, when you're sitting in front of a patient and they've come in because they have a cough or something funny was found on the chest x-ray, and you tell them, I don't think it's anything, but just to be sure it's not cancer, I want you to get this, then I want you to get that done. At that point, you are no longer a shopper because you are no longer able to think about, well, I want to go home and I want to think about my plan. I want to look up who's the specialist, where will I save money? The simplest thing is to just go with the flow at that point, because the doctor says you get all this done down the hall, you're going to want to get that done down the hall. If somebody knows that, yeah, I can get it done quickly, I can get the same things done, but I can get it done at no cost. All I have to do is call one number. Then they can regain some of that sensibility of being a shopper.
So this is why you said this program is never mandatory. They were empowered to make this decision and they chose to go the route that you're talking about here. And now it's not disruptive if they need to text this number. It's actually it's a feature. It's not a bug.
We don't make it mandatory. As soon as it's mandatory, it smells like to people that you're being forced to do something.
I'm going to ask you 3 questions now because I know every plan sponsor listening is thinking 3 things. So I'm going to tell you what the 3 questions are, and our listening audience, again, spoiler alert, this is where we're going here because everybody's thinking the same things that I'm thinking right now. So let's just level set. The 3 questions everybody's thinking now are, number 1, direct contracting increases utilization, at least in the short term. That's going to be the first question I'm going to ask you. The second question I'm going to ask you is, how do you operationalize this? And not just what you're talking about now, like, oh, you give everybody an app. I mean, on the back end, because we've all heard the stories where somebody goes to a directly contracted provider and then the plan sponsor gets the bill from the provider, but then they also get the insurance bill. Like whoever the carrier is also sends a bill, just like that whole mishigas. And then the third question is, how do you make sure that plan members actually use the service? Because it's one thing to tell everybody something on enrollment day or open enrollment day, and then another thing for them to remember this in the heat of the moment in June. So how do you ensure that costs don't inadvertently go up? We did talk about the win-wins here, that the doctors don't have to hotbox patients, but oftentimes another advantage that is touted for why a provider organization should direct contract is that there's no pre-auths or prior auths. That's often put in the mix. And so you can see that if you get rid of all the pre-auths and prior auths, that utilization, that costs go up.
That's a great question. And it's a question we get asked virtually every time we talk with a potential client. The first is, the question is being asked wrong. It's, how do I know that I won't have excessive utilization? The answer is, how do you know right now you're having insufficient utilization? And good studies have shown that all impediments that you make to getting things done for people through prior auth, whatever, impede necessary care more often than they impede unnecessary care, often with devastating consequences, as anybody who's reading medical news now knows. And we've just seen the major health plans now begin to pledge that they're going to be reducing the burden of prior authorization and so forth. The fact is that, yes, there will be initially some increased utilization. Why? Because when you announce to your company that in January, you're going to be able to get so many things that you would normally have to pay a copay for, you're going to get them at a zero cost. People will delay getting things done. We see that all the time. But whether or not they get excessive care, I don't think it really changes doctors' behavior. It reduces the burden of trying to prove that somebody really needs something. And I think if you work with good doctors who follow established guidelines, that you're not going to have excessive utilization. Your biggest fear in a company is people not getting done what they should get done.
Something that you had told me before is that conservative care sometimes costs more than surgery. So the zero copay isn't just relevant to surgery, because if a patient has money in their decision-making criteria for how to proceed, the cheapest route, weirdly, again, is sometimes surgery instead of doing the physical therapy or et cetera. Okay, so all of this being said, it is often said that when you reduce patient out of pocket, you increase utilization because now it's free and people just go and get lots of care. I did a show, the Throughline show about moral hazard that I would recommend if somebody wants the 15-minute diatribe on this. Go back and listen to that. I do feel like, though, this is a little bit different. If someone hits their deductible in November, they feel like they've got to do everything possible to do by the end of December while it's still free. So you kind of compress and exacerbate the moral hazard problem there, or the patient's feeling like now the clock is ticking. But anyone listening, I'm sure you're kind of going through the same mental gymnastics I am right now.
I'm just going to say there's two things that most prior auths will wind up being overridden when the doctors send in the necessary documentation. So yeah, you may just delay it getting done and it may show up on next month's books, not this month's books. But the second is that we know clearly that any impediments to necessary care, whether they're social impediments, moral impediments, financial impediments, will reduce necessary care. And that's why if you're going to offer health benefits, your plan, by golly, needs to benefit health.
That's something that maybe we should all reflect on every now and then. Like, what are we doing here? Are we checking a box or are we actually trying to improve health?
Exactly.
All right, here's the next question for you, which I know is everyone's thinking, how do you actually operationalize this? How do you actually make sure that people aren't getting double charged by the carrier, that it doesn't turn into total chaos trying to administer this?
Actually, double charging turns out to be a very minor problem for one very special reason is the members know that their services are at zero. If they get a bill for their service, that means it was double billed, and that's very easy to rectify. How to operationalize it? It's really simple to operationalize something that's easy to understand. At Zero, we've got a plan where it just takes a few hours of HR's time or who's ever going to do it, but we make it simple. We do all the promo work, we do all the graphics, we do all the email, and everything is tailored to the company. We have a company here in Tulsa that has a large Spanish-speaking population, manufacturing company. Everything is bilingual that we send to them.
And what you're talking about right now is how do you recruit for the plan? How do you explain what the plan is? How do you train the employees what to do? How do you get everybody on the same page relative to what to do and then remind them across the course of the year the plan that they signed up for? So that sounds like one aspect of operationalizing the plan. The other one, though, is, okay, so patient walks in the door of a clinical organization. Hi, I'm here to check in for my surgery. What happens now?
Everything has been arranged so far so that when a patient goes to a particular provider, like our surgical hospital here in Tulsa, everything has been done at that point.
The one thing that you hear over and over again is that the front desk is baffled. So it sounds like not only is there training that needs to go on at the member level, but also any provider that signs up, there's some kind of full office training that needs to happen there so that when the patient walks in and flashes some card or their identity or whatever, they're not like, I've never seen this card before, so question mark.
Yeah, we have a provider experience team that does that to educate people.
These are all pre-scheduled things. You have, as you said, somebody got navigated over there. So the navigator now knows that a patient is going over to whatever place. Paperwork gets done on the back end. And then the doctor just simply sends the bill to the right place because they have a very vested interest in sending the bill to the right place. So they know that even though this patient's umbrella carrier basic plan is pick a buka, or pick a different TPA, that this particular service, the bill should get sent directly to. And it sounds like most provider organizations have a sophisticated enough billing department that they can do that if-then equation.
Yeah, we make it really simple. I mean, they can send a regular claim from their electronic health system. They can send us an invoice. They can send us fax us something on the back of a clean napkin. I mean, it really doesn't matter because we make this the simplest way to go for the provider, for the employer, and for the member. It's all about simplicity.
Isn't that a concept? Keep it simple, stupid, right?
Everything is so simplified that we're removing all the friction and additional expense of going through an insurance mechanism makes the money more readily available without threat of clawback or denial. They know what they're going to get and when they're going to get it. I think it was expressed best by one of our very first providers, Surgery Center of Oklahoma.
And this is Dr. Keith Smith, who I know is very active on LinkedIn and elsewhere.
But the testimonial he gave us could stand by itself in advertising to providers. He said, 0 patients come to me. They are pre-qualified, well-informed, and ready for care. I was talking to Dr. Smith the other day, and I asked him, what is your clinical to administrative staff ratio? And his is about 10-1. And I said, well, the industry is like 2-1. And he said, I can't believe that because he does virtually all bundled care now. He doesn't have a department to do collections. He doesn't have to send letters out.
So the point that you're making this is another provider advantage that if you just look across the industry, most people have one administrator for every 2 clinicians, which is nuts if you start thinking about it. Like we start talking about administrative load, administrative overhead, like whoa. And in Dr. Smith's practice, he's got 10 clinicians for every 1 biller just because it's so much simpler to administer a bundle in this way than to try to figure out how to get through the coding gauntlet of some of the carriers.
Yeah, and there's no accounts receivable. You know, every physician's dread is to have 100 Stacey Richters who each owe them $15 but want to pay $5 a month. I mean, it just isn't worth it at that point.
As a lot discover, the more employers that do that, the more that we're protecting our indie practices also.
Yes, and that is one of the prime motivations for me. I think that the physician always needs to be responsible to the patient and should not be making fiduciary decisions for their employer.
So the last question I promised to ask you, which I think you already answered largely, but I'm just going to ask it just in case you have anything else to add, is how to ensure plan members actually use the service.
Actually, there's a couple of things there, but it's service after the sale that makes a huge difference. Let me explain. We go through the education of the employers. It's all customized to the way the employees and their family members are used to receiving information. We say, let's put this off open enrollment so that this program, which is extremely important, doesn't get sandwiched between dental benefits and vision benefits. We'll do it off cycle. It can be done anytime. The second is we will customize the education for your employees so they understand it and make people available. We'll go on site. We'll do whatever we need to do to be sure people know how to use it. Here's the secret, though, is after the program starts, we will continually review claims, PPO claims, typical insurance claims from a company, and we will match those to what Zero could have done. And we call those missed opportunities. And we expect in the first year of the program, we'll get about 30% of the things that the Zero program could have done under Zero. But by the end of the second or third year, we expect that to go way up. And some of our best performing companies will get about 70% of Zero eligible services actually done under the Zero program. And, we think that's where they really start to see both the savings and money. But importantly, it's a huge retention and attraction for hiring new talent. We've seen over and over again, school systems in Colorado, for example, where we have a number. People come in and one of the benefits they ask for is, do you have zero? Because, that's where I want to work.
We can't underestimate the zeitgeist that we're in. Americans are hyper aware that healthcare costs a lot. Not to this level. I feel like, have we ever seen this before? We've got a family of 4, costs $35,000. You get somebody who's making $85,000. Okay, that sounds like a lot of money, except you start subtracting out the amount of healthcare dollars that are in there. Dave Chase has talked about the stagnation of the middle class wages. And this is why. So you offer something like this. It not only do they start thinking, wow, there's cost savings here, but also just uncertainty breeds anxiety. So you're like, okay, well, I'm doing something really good for my family here, where I am making sure that we don't, in the casino of healthcare, accidentally bankrupt ourselves. But the other thing I just want to point out, which I think is, it takes a level of sophistication to figure this out, that we're not creating this binary scenario where it's either 0% direct contracting or 100% for this plan population. As you said, you can tick the needle up. So if everything goes well, you can get 70% or more, which is indicative to me exactly what you're saying, that this is a pull, not a push. And whatever percentage you get is a percentage of everybody getting the advantages that you're talking about, but that can tick up naturally over time and organically so that disruption is minimized, because when this service is taken advantage of, it's done very consciously and everybody knows what the drill is.
Yeah, if you're a company that has direct contracting for advanced primary care, and then they have zero for direct secondary care, you can provide much better health care, save money, and save money for your employees and their families. We give advanced primary care the opportunity to save money for the things they can't do in the office.
Dr. Stan Schwartz, is there anything I neglected to ask you?
Just that our program is not revolutionary. It is a simplification of what takes place now. We make things easier for your members. We make things easier for your bottom line, and we make things easier for the doctors who work with us. It is pure simplification, and it's removing all the excesses in trying to give routine healthcare through an insurance mechanism that was never meant to take care of things that you expect to happen.
So keep it simple. Dr. Stan Schwartz, if someone is interested in learning more about Zero, where would you direct them?
I'm on LinkedIn, Stanley Schwartz, MD. My co-founder, Jim Milloway, is on LinkedIn, James G. Milloway. Or you can go to our website, ZERO.health. Or you can send us an email at info@ZERO.health.
Dr. Stan Schwartz, thank you so much for being on Relentless Health Value today.
Thank you, Stacey. Hi, I'm Dr. Stan Schwartz from ZERO.health. Relentless Health Value has been a real source of insight and inspiration for me. Every episode feels like a thoughtful, informed conversation that really gets to the heart of what matters in healthcare. If you're committed to moving the needle in this space like I am, I strongly recommend subscribing to Relentless Health Value newsletter. For me, it's the best way to keep up with new episodes and stay connected. Thanks for listening.